Welcome everybody to EMTV. We are still on vacation. Let's get on with the news.
EMTV news.
There is an FDA alert for LVADs, the left ventricular assist devices. The alert is for increased rate of pump thrombosis as well as high rate of CVAs in specific models. So all those LVADs you see at St. Lucie, keep an eye out for that. In the British Medical Journal, a meta-analysis of age-adjusted D-dimer for PE rule-out has found that it is effective for patients greater than the age of 50. The age-adjusted D-dimer had an increased specificity without a change in sensitivity. The New England Journal of Medicine has shown that non-dilated fundus photography helped improve the identification of TIAs in the emergency department. Retinal vascular abnormalities seen on fundus photography, along with a ABCD2 score, help differentiate TIAs from TIA mimics. Of course, the $15,000 device does not come with a battery charger. That's $6,000 extra. Let's get it on with the rest of the show.
With the microphone. Needs a little Viagra. Here we go. One moment, please. Ooh. There you go. There you have it, ladies and gentlemen. We've given the microphone some Viagra. All right. This is a quick EM Wrap episode. Nick Tester, assistant professor of emergency medicine at USC, is going to be talking about iritis. It's a short segment. It's getting back to where we should be, which is short segments on EM Wrap. And it's about iritis, how you diagnose iritis clinically, and how you diagnose it on slit lamp, because this is something that comes up very frequently. Is it conjunctivitis or is it iritis? There's a few things you can do that'll help you get the diagnosis. Clearly, the treatment is very different. Conjunctivitis? Who cares? Iritis, cycloplegics, steroids, close follow-up. So you need to know the difference between the two. MRAP September 2008 is done. The audio is done. Should be posted soon. So, we haven't been getting much feedback from you about the old MRAP TV. But I am going to tell you about a whole new thing very soon called EM Wrap Core Content, or EM Core Content, where we put all the lectures in one place and the short MRAP TV episodes in another place. But more on that later. Let's get busy. Nick Tester, do it.
Case 4. 44-year-old male presents 6 hours after being poked in the eye with a pool cue. Patient slowly developed decreased vision, pain, and photophobia. Visual acuity is 2100 in the painful eye. And you look at the eye and you see this. What do you got? Anyone? Traumatic iritis. How did you know that? You are a genius. And the history. Okay, good. So it was trauma, slow to progress, a lot of pain, slowly decreasing visual acuity. And what are the other findings we see on this? Right, so you have no perilimbic sparing, also known as ciliary flush, right? This erythema that goes right all the way around the cornea, okay? This is indicative of an inflammation in the deep portions of the eye, particularly the ciliary bodies. We're going to look at some images that are going to help you understand this a little bit better. The other finding here is the constricted pupil, right? So the traumatic iritis typically has that very constricted pupil and that perilimbic, or that ciliary flush, that erythema all the way around. When you have a classic conjunctivitis, erythema is typically worse at the far aspects and then gets better as you get towards the middle. When you have an inflammation of the iris, the ciliary bodies, or the deep portions of the eye, the inflammation typically is worse right in that perilimbic area and gets better as you move outwards. Is that clear to everybody? Okay. So, we're talking about a traumatic iritis. This lecture is really composed of areas of deficit in my knowledge, all right? So I read about all the stuff that I never really understood. I never really understood what the difference between a uveitis and an iritis is. I have a friend who's an ophthalmologist who did a fellowship in uveitis, okay? There's a whole specialty to it. It's far more complicated than you may ever understand. He's a uveologist. Uveitis is an inflammation of any or all of the uveal tract. The uveal tract is composed of the choroid, okay, which is this deep vascular portion of the globe, the ciliary bodies, which are the muscles that anchor the lens, and then the iris. Ooh, where'd my pointer go? Then the iris. This whole portion is the ciliary tract. When you have an iritis, you have an inflammation of just the iris. Okay? When you have an iridocyclitis, you have an inflammation of the iris and the ciliary bodies. Typically, what we see with traumatic iritis is that combination of inflammation of the iris and the ciliary bodies. But there's no way anyone wants to walk around saying iridocyclitis. So we typically just call it iritis. But that inflammation goes deeper into the ciliary bodies. That's important when we talk about treatment, which we're going to get to on the next slide. So, traumatic iritis. How do you make the diagnosis? Well, you guys did a great job. You looked at the history, and then you looked at that eye, and we saw that ciliary flush, and you saw that constricted pupil, and you said iritis. But there are some other classic findings that I want you to be aware of. Cell and flare in the anterior chamber. This is a collection of proteinaceous material or cells in the anterior chamber that can be seen on the slit lamp exam at its highest magnification when you shine that beam through at an angle. Very difficult to describe. This is a mediocre picture of it. This is the lens. This is the iris. And this beam of light going through the anterior chamber is proteinaceous material. Okay? That's that flare. That is consistent with an inflammation of the iris. Okay? You have white cells, you have inflammation, and it's spreading into the anterior chamber. An easier finding is the consensual photophobia. So when this patient came in, they were struck in the right eye. They had a lot of pain in that right eye. When you shine a bright light in that right eye, it hurts because that pupillary sphincter that's cranking down on the iris is in spasm. And every time you shine that light in it, it causes it to spasm more. Now, if you shine the light, though, in the contralateral eye, so he was struck in the right eye, now I'm shining the light in the left eye, again, he's going to have pain in this eye because the pupils are trying to constrict together, okay? That's consensual photophobia. You're shining the light in the left eye, no pain in the left eye, but pain in the contralateral eye. Does that make sense to everybody? Questions on that? All right, good. Amazing.